Welcome to In the ED Now, a podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Rebecca Griffith. Today we're speaking to Dr. Stephen Kinney about opioid use and overdose, how to know how to help these patients the best you can, as well as how to make them more comfortable and decrease some of the stigma around these issues. You won't want to miss this episode. Thanks for listening. Welcome back to In the ED Now, a podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Griffith, and I'm really happy to have with me today Dr. Stephen Kinney. Welcome to the show.
Thanks for having me.
I'm so excited to have you here. Can you tell people a little bit about yourself and then we'll dive into the topic?
So I'm a physical therapist and I work at Palisades Medical Center, a part of Hackensack Meridian Health in New Jersey. I know it's a very long name. It's a little wild. But I tend to see work in the acute care setting and the outpatient setting there. And I tend to see everything that comes our way. So board certified in orthopedics. So I like tackling everything. And I think sometimes that's what's a little lost in our field sometimes. We become so super specialized. We really need people who can connect those silos a little bit more, like an ED physical therapist.
Oh, if you want to get me started on my favorite soapbox, it's that we need a few more generalists or people who are specialists at being generalists and putting the pieces together. I get accused a lot of the time of saying that we don't need specialists, and I absolutely don't think that's the case. I think we absolutely do need specialists, but we do, just like you said, need somebody who can put all the pieces together and connect people to the right people. I
Right
love
on.
that. Okay, so you seem to have a little bit of a special interest around opioids, yes?
Yes, that's definitely, especially as I got more into treating persistent pain and the challenge of that over time, I started to seek out different opportunities working with other, not only rehab professionals, but just different healthcare professionals. And we started forming some of these community relationships. And then before you know it, really started going into naloxone training and thinking about how this could be relevant to the field of physical therapy and how this a lot of time could be a start of the conversation about how PT fits in that whole spectrum of opioid use and uh, some people use word misuse as well. Both those things.
I love that. And I think physical therapists absolutely should be part of that conversation. And I know just in my experience in the emergency department that the tide has shifted. Like when I talk to students about case studies from the ED, like one of my first cases is like PT eval and treat for low back pain, patient's been given morphine and is pending an MRI. And that was like at the time, like that was, and I'm like, why are we getting an MRI? And they're like, well, to rule out signs of cauda equina. I'm like, what symptoms of cauda equina does this patient have? None. Okay, so like maybe let's not do that. And then an opioid in a 64-year-old female who already has a baseline oxygen requirement, is that a necessary first step? And so the transition though has been stark. So I would say now patients almost never get an opioid in the emergency department unless it's something really significant. So, can you speak to how things have changed and why they've changed to where they are now?
That's actually a loaded topic too, because I
Yes.
think there's so many points in time where, like you mentioned, where we used to give the opioids out like candy, and that really led to the opioid crisis being what it is today. I remember even for myself, I had shingles when I was like 20 something years old. And I remember telling a doctor, I have no pain whatsoever. And they kept pushing opioids and opioids. And I'm like, I really don't need this. It's ridiculous because I don't have any pain. So why are you trying to give me this? And it's ways like that eventually that got people into opioid crisis. If you look at how it really started, two of the really big areas where it happened was dentists actually over prescribed opioids and a lot of primary care physicians because they just wanted to manage pain. Everyone wanted these things. So I'm glad that pendulum has shifted where we're moving away from opioids for acute conditions. But in some ways, there's some perils too, because now we're almost shifting a little bit too far because there's been people who, in the words of patients who I've worked with, I've been on enough opioids to kill an elephant. And when you drop down that person really far in terms of their opioid dosage, you actually cause a lot more problems. And that caused really the whole new like heroin and fentanyl era because now you weren't giving people anything. You stopped people, in some cases, cold turkey, in some places, just it was similar to cold turkey. The new guidelines for opioid prescribing guidelines are addressing that, but so much of that damage has already been done. So weirdly, as a physical therapist, I've learned there are sometimes people do need to be on opioids, and sometimes even at higher doses than we expect. So there's that acute side, which I think we're doing a lot better at. But now we're really not serving those patients who we for lack of a better term, screwed over like all those years ago. And now we're just compounding the damage that we're doing to them.
I think that's fair. I think there was a retrospective study in the emergency department that 17% of patients were still leaving with opioid prescriptions. And I know the emergency department can be a source of opioid prescription addiction because patients will start there when maybe that wasn't the best choice. So I think it's a good opportunity for physical therapists to intervene at those moments when patients are in acute pain and help them see that they can work through that pain and maybe they don't need opioids. But I agree there are times when they do. But I also agree with you that there is still some culture around pushing pain medications. I remember I had knee surgeries several years ago and I felt like I needed those really strong prescriptions to get through it. This is before I went to PT school. I didn't know any better. Everybody said, take these pain meds to stay on ahead of the pain, stay ahead of the pain. You don't want to feel the pain. And then I just had this massive foot surgery in November, and I was like, no, I don't think that I'm going to need any opioids. And the physicians were like, no, you have to fill this prescription because you're going to be in so much pain. And I'm like, well, I teach people how to manage pain in non-medication related ways. I think I'll be okay. They were like adamant before the surgery that I would at least fill the prescription. And I didn't end up needing it, and I was able to manage the pain in different ways. So I just feel like everybody's different, and how we know it belongs to physical therapy is because we're going to say it depends whether people need it or not. But for me, the way I knew that there was an opioid crisis, where it like hit home for me, is I had a patient come into the emergency department and that she was there ostensibly for low back pain. And she really mirrored my lived experience. She was my age, she was my race, she was my socio-demographic profile. She had 3 children, same age as my kids. We could be alternate versions of one another. She had a career. And when I got in the room, she said, no offense, I don't really want to talk to you. I want to speak to a physician about whether I should switch to heroin or meth because no one will prescribe me any more Percocet. And I don't know what I'm going to do. And I'm addicted. The reason I came here is because I am hoping nobody will judge me. And I just need to know which one's better, which one is better for my health, because I'm going to have to make that choice now. And that was that moment for me where I was like, we need to do something differently. And so when I met you and you were talking about naloxone, I thought PTs need to know about this. So talk to people about that.
Yeah, and I think the case that you brought up is actually, we can even go further into that too, but that's a person who really needs to have naloxone prescribed to them or given to them. And for people who are listening, naloxone is now over the counter everywhere. There's plenty of free resources to be able to get it. One, I get no kickbacks from them or anything like that, but endoverdose.net is one place you can get it. If you're in California, generally it's totally free, but I think everywhere else you have to pay a shipping fee. But there's also plenty of other places where you can get free naloxone. And this is a medication basically where you can save someone's life if they're having an overdose. So if they're having an overdose, you give this medication to them. In the research, it's about 80% effective. That might be a little bit high for the fentanyl era, but still 80% effective in saving someone's life is awesome. If you look at CPR in the best of circumstances, you're only looking maybe 20% in terms of saving someone's life. So this is something we all really need to be able to do in every setting. And I think I know you're probably a little bit more aware of this since you're on the House of Delegates, but they had a position statement they made a few years ago where naloxone should be available where physical therapy services are provided and people who are able to administer it as well.
Correct, because a lot of our patients are in pain. A lot of our patients are taking opioids. And it's just like every clinic should also have an AED. We are exercising people who have comorbidities. I would think opioid use is something we need to be prepared for as well. And so for people who are like, I'm not trained to administer medication, that's not in my scope of practice, what would you say to those people?
If you are listening to this podcast and understand what we're saying, you are able to administer naloxone. And that mean you're a PT, you're a PTA, a student PT, a student PTA. You could be a 90-year-old grandma. You could be a teenager as well. It doesn't matter. It's really not that hard to do. And it's more important that people do it. Because when you administer naloxone, it's Generally, what you're going to use now is you're going to use like the nasal pumps. That's the most common delivery method right now. So it's just little one shot thing where you basically stick it up someone's nostril and then you push the bottom as a piston and then it's administered.
It's
The
like
big,
Flonase.
exactly. The big thing that you have to do is determine if someone's having an opioid overdose.
Yeah, how do you
And
do that?
a lot of the big signs, great question, is signs of central nervous system depression, where you have someone who's not breathing, not responsive. They have extremities, potentially like clammy hands, those types of things, where people are just really not responding to you. And guess what? If you guess wrong and you give someone naloxone, you're not it's not going to be toxic to them. It's not harmful. Really, what it does, it just reverses the effects of opioids. So you will cause some withdrawal for people like that. But if they're not breathing, they're going to need those services. They're going to be going through withdrawal at some point, regardless, anyway. The way you administer naloxone is you would give it to them first, and then you would wait a couple minutes before administering that again. And during this time, you can still administer CPR and do all that kind of thing. But the reason why you don't give it a bang right in a row, like 3 doses, is because if you do that, there's a really good chance you're going to precipitate a really rapid withdrawal. And when you hear
Mm,
about people who get a little cantankerous after having naloxone,
yeah.
that tends to be the case when you really rapidly withdraw them from it. So that's something I would caution people about. This is why you have those 3 minute wait times. And the risk of someone getting angry and getting hostile or violent with you is still very low, but that will increase the chances if you just really overdose them quick and early on.
But you're not going to hurt anybody. And I think that's something that people worry about. They're like, well, what if I'm wrong and I give it to them? It's what if somebody's not breathing and you don't give CPR because you weren't sure they needed it? You're in a liability position a little bit if you're just watching that happen and you have the tools to stop it, correct?
Yes, with the liability point, there was in one state I know in particular, the attorney general of the state, and this was also, if people sometimes wonder from the naloxone's like a red state versus blue state issue, this was in a red state where they said this, the attorney general in the red state was telling law enforcement officers, hey, if you don't want to administer naloxone, just realize that you actually could be facing greater liability if you don't provide it than if you provide it and it goes poorly. So they were trying to warn law enforcement about that. Because in terms of safety, I'm sure you've heard in the news about like fentanyl exposures. Have you heard
Yes.
about that?
Oh, yeah.
So in terms of fentanyl exposures, some of the symptoms that people will have who respond to opioid crisis, they administer naloxone or administer care to someone who's having an overdose. A lot of times these respond violent shaking, that kind of thing. Now, do those signs and symptoms sound similar to what I was talking about before with an overdose or a little bit different?
A little different because one is more suppressed and one is more active, yeah?
Yes. So one of the things that they found out, and they've done research on this as well, these people are probably having panic attacks, which is not
Oh,
to what's it called, make fun of them or make light of their situation, because that's a significant thing, because it's scary when you go into some of these
yeah.
emergency situations sometimes. But it also creates stigma of why people sometimes don't want to administer naloxone. This fentanyl could puff up in the air and then I'll inhale it and then I'm going to have an overdose too because one little speck is going to cause me to have an overdose. And that's panic inducing for people, but that's not the case. You're not going to have an actual overdose if you're just near fentanyl. You can take fentanyl and rub it on your skin and you're not going to have an overdose because that's not the way that it is taken in by the body. So there's fentanyl patches that people use, and the only way you can get it transdermally, the fentanyl, is because of the way that patch is made. You just can't rub raw fentanyl in your body or touch raw
Right.
fentanyl and have an overdose. So I think that's really important for people to know about that safety point
It's not
because
like
it's a barrier.
secondhand smoke.
Exactly, yes. So if you
Okay.
go and if you're at the scene and you decide to, what do you call it, like snort or eat some of the fentanyl, then maybe you're in a different category.
You're on your
I
own.
recommend against doing that.
Yeah. Okay. I think that helps people also because the way that it is portrayed, I think does cause a lot of stigma and people may not want to help. And to me, that reminds me a little bit of the HIV virus where people like didn't want to touch people because they thought if they touched people, they would automatically become infected. And that's not the case here.
Exactly. There was a place, so they found a place that I work recently found a lot of bags of fentanyl. I remember security found it and they were like, don't touch it. You could overdose and that kind of thing. I was in my head. I was like, oh gosh. Putting the gloves on, it's fine. I'm not going to worry about it. But these are some of the conversations that we need to work back a little bit.
We need to debunk that. So, just to summarize that, naloxone is a life-saving medication. It's easy for physical therapists to administer. The APTA recommends that physical therapists are administering this as needed. It's easy to access in almost every state. And there's likely to be more liability if you don't intervene than if you do.
Exactly. Yes. And
Great.
I know people are concerned everywhere about the whole liability thing. In all
Mhm.
50 states, there's legislation where any lay responder can administer naloxone. So
Love
I
that.
know it gets people concerned. I also tell people, like, if you keep it in the medicine cabinet and my 3-year-old, if she gets naloxone and plunges it up her nose or eats it or something like that, she's going to be fine. It's not going to have any effect on her whatsoever. So it's, I really can't stress the safety of it too much.
Wonderful. So, my next question for you, because you do work with patients who use opioids a lot and who might need naloxone, is they seem like they face this huge stigma, especially in the face of the opioid epidemic and people like demonizing opioids and the people who use them and discounting everybody as like a drug seeker. Can you speak to how we can interact with our patients in a less stigmatizing way and advocate for our patients?
And I don't think some of it is just for all of our patients, some of it's a little bit more specific to opioids, but there's been a push recently to use kind of person first language when we treat or we work with our patients. And you don't refer to someone as, oh, this is Parkinson Bob over here, or that's my sepsis patient. It really should be, that's Dolores, my patient with sepsis. And so, same thing with individuals who are using substances. You wouldn't call them the addict or that kind of thing. And addict is a really particularly stigmatizing word. Even if you say, oh, the one with substance use disorder, that's also probably not the best way of doing that either. You could say, no, this is Bill and he has substance use disorder. So using that person first language can be really important. There's also I've worked with a lot of harm reduction groups, and harm reduction groups are trying to help people who are using substances use them in safer ways and also use them in, how should I say this? Like when they do choose to use substances, be able to limit some of the harmful effects.
Mhm.
So some of the information they've talked about in terms of describing someone's substance use is use the word substance use, not substance abuse. This is not someone, because sometimes people can use substances and be relatively stable. I know it is a little bit harder sometimes with fentanyl and heroin and those types of things. And you think someone could be stable who uses cannabis, but there are people who can be stable using opioids, which I know is a little bit shocking to us, but people are not overdosing every five. There are some people who are out there who aren't overdosing every 5 minutes. So really trying to use substance use as the word that we kind of use for people is really important. And people think that this stigma doesn't matter, but it really does, because the more stigmatizing attitudes that you have towards this population, there's a direct correlation to these people get worse care, because there are really great treatment
Mm.
strategies out there for opioid use disorder that they don't get. And that is linked to stigma.
I would think it wouldn't be great for therapeutic alliance either. And I have so many patients who come in and they're like, my pain is real. They're treating me like I'm just looking for pills. I don't know what else to do. I'm happy to do whatever you need me to do, but I'm not like a drug person. And it's hard. And it's hard to build trust with patients who feel like they're being treated that way.
So you set me up volleyball wise. I'm just going to spike that down now. So there's actually a study out there. We worked so hard on trying to get this therapeutic alliance with our patients. And by just being trained in naloxone and being able to talk about naloxone, we could dramatically improve our therapeutic alliance. There's a study by, I think the name's Kieran, Kiran. I don't know if I'm pronouncing that incorrectly. I apologize if I am, but they looked at individuals who, healthcare providers who are willing to talk about naloxone with patients who use substances. And for the physicians and other healthcare providers who are willing to talk about naloxone to them, 99% of them said that it would form a better relationship with their provider. So I think that really speaks to the importance of knowing these things and creating a therapeutic alliance with our patients.
I think you're absolutely right. And I think too, I read an article about a woman who lost her son to drug addiction. He overdosed and was not able to be revived because he was alone and there was not anyone with naloxone. And so now she opens up her home for people who are using substances to make sure that they're at least doing that safely so that she can monitor them and make sure that they're safe and can administer naloxone if needed. And I had so many mixed feelings about that because I thought, gosh, like on one hand, some people would say that maybe she's encouraging drug use, but on the other hand, our system really isn't set up to help people in any way, and she's saving lives that way. So, what do you think about that? I think talking to your patients about that is also important.
And we really need to embrace harm reduction in our field because
Yeah,
by having a conversation with someone, be like, hey, opioids are bad for you, stop. And it'd
right.
be great if people stopped, and that was awesome. And hey, abstinence is probably, I should rephrase that. Abstinence is a good way for most people with most substances to get better. With opioids, it actually is a little bit more challenging. You probably people who get medication assisted treatment actually do better than people who go cold turkey to straight abstinence for a lot of reasons. But beyond that, I would say harm reduction, its values harm reduction. So people might not be doing the exact perfect thing for themselves, but they're going to do something that's safer. So when you do use substances, using it with someone else is some educational advice that we can give patients to keep them safe. So with that patient, you could be who you were talking about earlier, but okay, here are some ways that you can be safe if you're choosing to use these substances. Make sure that you use with someone else. Make sure that you go to the same dealer consistently. Don't hop around a little bit because that'll help it with some of the consistency of the product that you're using. There also can be advice in terms of like with the with IV drug use of like where you inject. So this may sound really common sense to us, but if you have wounds from your IV drug use, don't inject into those wounds because it's going to impact your healing. I know sometimes it's easier and you'll get a faster high, but you need to use different sites on your body. And this is just just a small kind of snippet of examples that we can educate people on, I think could be very valuable in the emergency department. And you were talking a little bit about a safe consumption site. Do you have safe
Yeah.
consumption sites in Colorado?
I'm not sure. Now that you say that, I'm not sure. We're way more lax about drug use in Colorado in general. I think with our legalization of marijuana and mushrooms and some other substances. So we do see a lot of people who are having difficulty with those types of substances, in addition to heroin and fentanyl and things like that. But I'm not aware of any safe sites. But that, now that we're talking about it, I feel like maybe I need to be aware of that.
Yes, because that could be another education point for your patient. So it sounds like this individual is great and she's creating a safe consumption site. There are ways to, there are some states where there's designated safe consumption sites. So you go and you bring your products and your substances in, and then you use them and you're supervised this whole time. So if you do have an overdose, there's someone who's able to help. You're going to use like clean needles. So that way it reduces the risk of some of the infection diseases that you get sometimes when using needles. So these are all different things that can be really valuable for a patient. I know not a lot of states have them, but it can be very valuable. It saves lives basically, and there's research to support that as well.
I feel like a bar is a safe consumption site for alcohol to a certain extent. Somebody checks your ID and they give you alcohol and they stop serving you when you've had too much to drink. They take your car keys if you can't drive. It feels very similar to me and has less of a stigma. Do you know why that is? Like, why is this so different from that?
If you look at the research on alcohol, it's maybe the risk of overdose is lower, but alcohol in any capacity, the research has come out recently is alcohol in any capacity is not healthy for you. If you have that one drink a day, I know people cite the studies about one glass of wine a day. It's great for you, how that can be actually a health benefit. They've looked more into that in the research. I think this was published in one of the higher quality journals. It might have been JAMA, but I could be wrong. But they controlled for socioeconomic variables. And the
Hmm.
reason why the people who have a glass of wine a day do generally have better health is because they tend to have a higher socioeconomic status where you can afford a leisurely glass of wine a day. Really, It's more that than the effect of actually alcohol being a positive. And guess what? I have a beer every once in a while and that kind of thing too. I know that there's risk with that, but we all can't be perfect. We all have fast food. So there's this
I'm
kind of
highly
sliding,
addicted to Diet Coke.
yeah. And there's not as much stigma with that in our
Correct.
country. So it's that kind of goes back to the stigma that exists for these people and for these people who are using substances. And we really need to be advocates for them. And we have that ability to do that in our medical system. And that's why I push so hard for this, because I'm teaching you the tip of the iceberg. But once you start seeing that whole iceberg, you could see the capacity for our profession to really be leaders and to really push and to integrate harm reduction into what we do and really transform care for these patients. Because we want to care for our patients and we want to have a greater say in our medical system. This is like one of the perfect ingredients for us to be able to further establish ourselves in our.
I like this concept of harm reduction in general, also for physical therapists, because I'm thinking about it's very hard to be perfect patient.
Mhm.
It's very hard. Like I saw this video of somebody who was like told they need by one provider they needed to eat 7 servings of vegetables, and then the next provider told them they needed to have 10 glasses of water, and then the next provider was like, you need to walk 15,000 steps a day, especially if you have a sitting job. And the next person was like 1 hour of cardiovascular exercise 5 days a week. And the list went on to the point where like they put all of those things into a day and then the person felt like they couldn't do any of it. So they stopped doing all of it. And so I think sometimes talking to our patients about small changes that can make a big difference for their overall health in like more of a harm reduction way. Like, can we stop this and add this instead might be a good approach to just think about patient education in some ways.
Yes, I agree. We shouldn't demand perfection out of anyone because we can't demand perfection out of everyone. I can't be perfect. You can't be perfect. No offense. I think you're mostly perfect. You're doing a lot of great things for a profession.
I
But
think too, like it doesn't take into account people's lives or their social determinants of health either.
oh no, absolutely not. And I think we're really lucky in our field because the interventions that we provide people are so low risk most of the time,
Yes.
where we don't have to have discussions about competing risk or being like this medication, there's an 80% chance that's going to be like TPA. TPA is a great example. There's what a 90% chance that it has a great effect on someone and a 10% chance it has a terrible effect on someone.
Yes.
And that is a tough decision when, for those of you unaware, TPA is the clot buster for individuals who are having a stroke when they come into the emergency room to help have them have a better outcome from that stroke. So it should bust that clot up and then they'll have a hunky-dory better outcome. But 10% of the time, it actually converts an ischemic stroke into a hemorrhagic stroke and can lead to actually worse outcomes. But that's some of the risk analysis that physicians in the ED have to make. And we're really lucky.
Hmm.
We don't have to make such profound risk decisions. But I think we need to wade a little bit more into that. And if we can embrace harm reduction, I think we can see maybe this isn't the best answer, but this is the best answer for you.
Yes. I love that. Yesterday I was feeling like just a little discouraged after I left the hospital because I feel like there's so much that I want to be able to do for patients and so much that I can't do for them. And I think to a certain extent, especially for emergency department PTs, that happens almost every day where we really want to fix everything for a patient and we feel like we know what they need and what the right choices are, but we can't get them those things that they need. And I think this is another one of those patient populations where there's so much we know we could do to make things better if they had the resources, time, opportunity, and like life that would support that. So I think this is just one small way that we can contribute to helping this patient population and helping society in a new way.
Yeah. And to be honest, combating stigma, it's a small step that you make, but it really leads to a much bigger changes. It's something you consistently do and you do change a culture. Because I was talking about so individuals who use opioids before, we didn't touch on this, but if you use opioids and you want to reduce your use or you want to wean off of it, people who do opioid agonist therapy, medication assisted treatment is the older term. Opioid agonist treatment is the better term. If you do opioid agonist treatment, which is using, I'm going to say this wrong because I always say this wrong, buprenorphine I swear I've been saying this for a couple of years and I just still can't get it straight. Boop is the what's called the abbreviated term that people use for, or methadone, are two really high evidence-based treatments that people with who are using who use opioids can really benefit from reducing their dosage of it and potentially also getting off opioids as well. They are opioid agonists. Yes, they're still technically counted as opioids, but stigma really is a huge barrier in people getting these very effective treatments. And I think that's why we have to combat the stigma and we have to be able to direct people to like that because it's those, if you look at the evidence for it, it is a very effective treatment, but people just aren't getting it. And we really need to be able to facilitate that. And we can refer the people to, hey, there's this good pain medicine doc, there's this primary care doc who I know is comfortable prescribing Boop to their patients. And I've worked on trying to make some of those connections with people too, for people in my own area. And they're not easy to find, but when you do find them, it can be an invaluable resource for these patients because there is so much we can do for them. And we think that sometimes there's not a whole lot we could do. That education on safe consumption can save someone's life. That's a huge deal. If someone
Yeah,
survives, that's the only way they can get better from opioid use. You can't improve your opioid use by dying.
right.
That's not a method to do that.
I know some emergency departments are starting to offer that as a service as well. So patients can come to the ED and receive that treatment and just leave. And I think that's another way that the ED functions as a safety net is that the doors are always open. Patients can come in and know they can get that medication and then they can go. And that fits really into anybody's life because it's open 24 hours a day. There's no judgment. They can come in, get that, and be on their way. So I
Definitely.
hope to see more of that. I have one more question for you that you and I talked about offline a while ago was that your emergency department has been seeing patients with wounds related to drug use. And so your physical therapists have been providing wound care around that. Is that correct?
I'm going to mostly correct, except that wasn't me. That was actually a
Right.
colleague of
But you're seeing some of that, yes?
so not at my this is not at my hospital. This is someone else who's a wound care specialist. She works at Temple. But she would be a great person to talk to because she works in acute care and the ED doing wound care for people who use intravenous drugs. There's a lot of wounds associated with that, especially
Yeah.
there's this new substance that's unfortunately the new craze sweeping the nation called xylazine. So people are getting these kind of weird wounds that's associated with xylazine use. And what it is, it's another sedative that's put into like the fentanyl supply, where it's supposed to potentiate the high, I believe. I don't think anyone really wants it in there. I just think it's just permeating into the drug supply and it does have some sedative effects. So I think that's why it's being put into some supply that we're seeing. But we're having a real big crisis with wounds with that. It hasn't affected my hospital quite as much because she's in Philadelphia, where I know Philadelphia is one of the epicenters for it. And I've also heard in Chicago, it's not doing so great right now in terms of these xylazine wounds. But especially as xylazine spreads, there's going to be an increased need for PTs in the emergency department to be able to manage these wounds. And the reason why PTs are well situated from my understanding, is since we're also pretty adept at treating lymphedema, and sometimes not all nurses are, it really starts coming into our wheelhouse a little bit more of managing these. I'm not the expert on this, but that's from my knowledge what some really pioneering people are doing.
But just something to be aware of. So if you're practicing in the emergency department, you're seeing patients with increased drug use, you're seeing patients with different kinds of wounds. There are resources out there, and we just want you to be aware, especially if you are the one providing that wound care. I know a lot of emergency departments have wound care nurses that do that, but there are emergency departments where the physical therapists are accountable for that. Okay, parting shot. What do you want to leave people with today?
I think the main thing is, you know what? If you think that this education wasn't enough, the resources were what we talked about in terms of getting you the free opioid use. They're going to provide you an online education for that too. Get in the lock zone, carry it on you. And I think the other big thing, this is the start of you being able to decrease the stigma that surround a lot of these patients, these individuals in general. Because even when you talk about opioids with people in your clinic who don't use opioids at all, there's a good chance that someone was affected by that in their life at some point in time. And these little steps that we take can really be meaningful. And so I hope more people take this on and run with it because there's a lot of possibilities here.
I love that. Thank you so much. You've been in the ED now and you're officially discharged.